Hi, my name is Dr. Manmeet, and today I will be talking about a disease affecting the elderly, which is osteoarthritis. It is rarely seen below the age of 40, but very common above the age of 70. It is said almost 50% of those above the age of 70 will have this illness. Now, it is part of aging, and it is also because of our human nature or our human evolution per se. Osteoarthritis affect the joints which are not meant to be used like the way we humans are using them. For example, our base of the thumb, our distal and proximal metacarpopharyngeal joints, and our knees, our hips. Ankle is also supposed to be affected. However, ankle is spared because of the fact that it is a very tough joint. Now, the basic pathological problem with osteoarthritis is that there is a destruction of the hyaline cartilage. Initially, it is patchy, however, it develops over a period of time and becomes more generalized. Cartilage is a very unique tissue. Initially, we thought that it is a vascular tissue, but now we know that it responds to stress, it responds to our action and loading, and it is a very active, metabolically active tissue. So, and it's also a very unique molecule. It contains a molecule called aggrecan. Aggrecan is a negatively charged molecule which are closely packed away, so they kind of provide a cushion for our bones to transmit weight, and it acts as a shock absorber. Now, what happens in this thing? There's loss of this. It's a joint failure in osteoarthritis. So what happens? We have these ligaments, these cartilages, these meniscus, and all the muscles which act in synchrony to prevent the joint from getting damaged. So, like whenever we are going from one stance to another stance, or we are like doing some kind of sports, our muscles they act in tandem and try to protect the joint by reducing the impact on the joint. Now, what happens in osteoarthritis? First of all, there's a destruction of the cartilage. Because of that, maybe because of the age, the oxidative damage, the chondrocytes are not able to to replicate that fast, and there's a patchy loss, and this leads to the subchondral bone to become sclerosed, and there's deformity of the bone as well. Along with that, there is synovitis, which is like inflammation of the joint, though it is not that much as there is in the inflammatory arthritis. However, it is still there. Then also apart from that, there will be deposition of these crystals, as I have talked earlier about the that CPPD, where the calcium get attached to the pyrophosphate molecule and get deposited inside the joint. The because of this, though we know that the cartilage is avascular, and it is a neural structure. However, the areas around that is not aneural, so there will be pain associated with that, which will lead to reduce movements of the joints, and it will also lead to disuse atrophy of the muscles, the tendons, the joints, and everything. So we have a genetic risk associated with osteoarthritis, which is because of this GDP5 mutation. It is growth differentiation factor 5, and there is also an associated risk factor. It is seen that those who are elite runners, like marathon runners and Olympic runners, they are at a higher chance of developing osteoarthritis later in life. However, those who are recreational level, you don't need to worry about it. You have like very less chance of developing it. Now, then there are certain things which predispose a person to develop osteoarthritis. For example, then there are joint deformities like genu varus and valgus and other things. They cause unequal distribution of stress over the joint, and this leads to destruction of that area where there is increased loading, and the body reacts to that. Another pathological hallmark which is there in osteoarthritis is that there will be from the margin of the joint there will be increased activity of osteophytes, and there will be deposition of calcium all around, and the joint will become sclerosed and all that. Now, what are the classical clinical features which are associated with osteoarthritis? The patient will be, you see an elderly patient which will come with typical involvement of this joint, but there will be very less morning stiffness. This is a distinguishing feature from an inflammatory arthritis, because the joint pain and this gelling phenomena is not going to be there as much in osteoarthritis compared to those inflammatory arthritis like rheumatoid arthritis. So the patient will have morning stiffness which will be less than 30 minutes, and it will improve slightly with work, but not that much. It's like very rare the patient will wake up in the middle of the night with pain. That is more characteristic of other arthritis, not osteoarthritis. So when we get a patient of osteoarthritis, we have to demonstrate the the patient. So basically, the diagnosis is all clinical. It's very rarely we need to do some lab test and all that. So we do a synovial fluid analysis in which the cell count is usually very less than 1,000, but there can be CPPD crystal which can be demonstrated in this synovial fluid. MRI and X-ray. X-ray can initially may be normal, but over time in advanced stitches, it will also show the that classical changes of osteoarthritis. MRI is rarely needed, though it can demonstrate these changes earlier. However, it is rarely used clinically. Now, whenever we have to manage a patient of osteoarthritis, we classify this treatment into first we have to do a non-pharmacological management because as we know that the muscle, the tendon, and ligaments are important part of joint stability. So we have to develop these muscles to prevent the loading on the joint. Then we can also use those neoprene sleeves which will provide some comfort to these patients, and we also use the joint loaders like this braces and other thing which will give a joint another way to transmit the load down to the ground. Now, among the pharmacological treatment we basically have those painkillers, NSAIDs. We too tend to give them. Initially, we got the COX-2 inhibitors. We were very excited about those, but then because of their associated cardiovascular mortality, we now have come up to, we have kind of ignored them a lot. We have naproxen as a very powerful drug, which has got less cardiovascular effect. We have other painkillers which we can use as per the appropriate doses. Steroid in osteoarthritis is very controversial topic. If there is an associated CPPD, there is a role. However, it will not progress any reduction in joint damage with any injection or intralesional injection of steroids. If nothing else works, if the patient is like really immobile and there's a lot of pain and all that, we can also offer the patient some kind of a joint replacement where the whole joint is replaced with a artificial one. There has been no reports. No, it has been we have been recommended against the use of those chondroitin sulfate and these kind of intralesional agents. They have been shown to be of no benefit in this osteoarthritis. So, guys, that's all about osteoarthritis. If you like my video, please do click it and don't forget to subscribe to my channel so that we can get regular updates about my videos. Thank you.